Good afternoon. Thank you for joining us. I'm Avital Havusha. I'm the Vice President for Programs here at the New York State Health Foundation. During today's conversation, as you know, we'll be building on some of the themes from some of our previous events last month and discussing solutions to support high quality primary care in the United States and in New York, which, as most of us know, is the foundation of a high functioning and equitable healthcare system. We'll start off by reviewing some key recommendations from a recent National Academies of Sciences, Engineering, and Medicine's report, and we'll discuss some of those implications for New York State, especially as we enter pandemic recovery. As the report points out, primary care is the only healthcare component where an increased supply is associated with better population health and more equitable outcomes. And as such, primary care is a common good, but we consistently underinvest and undervalue it, and primary care only represents an estimated 5 to 7% of healthcare spending in the US. So before we get started, I want to do a few housekeeping items for the day. We'll be recording the webinar, and a recap with the link to the recording and other materials will be circulated within a few days after the event. Video and audio are disabled for our attendees, but we invite you throughout the event to use the chat box to share questions and comments. And after the presentation and discussion, I'll be making sure we get through some of those questions. And now I'd like to introduce our guest today, Chris Koller. I'm excited to have him with us. Chris is the president of the Milbank Memorial Fund, which improves population health by connecting leaders to the best information and experience. And before joining the fund, Chris served the state of Rhode Island as the country's first health insurance commissioner, and he was the CEO of Neighborhood Health Plan of Rhode Island, among many other roles. He serves in numerous national and state health policy advisory capacities, and he was a core member of the National Academies Committee that published the most recent report that we'll discuss today. We have a lot to cover, so I'm going to turn it to Chris to introduce himself, to ground us in some of the findings of the report through a short presentation, and then we'll jump into discussion. So I'm just going to share my screen for everyone and we'll get started. Great.
There we go. Thank you.
Thanks, Chris.
Yeah, thank you. That's a great setup. Next slide, please. We've only got about a half hour, so I'm going to race through this quickly, and then so we can have a good conversation. The National Academy of Medicine, although it is federally chartered, relies on private contributions to move its work forward. These are all the folks that contributed to the sponsorship of implementing high quality primary care in America. I particularly call out 5 from the bottom on the right-hand side, and thank Avital and her colleagues for the leadership of the New York State Health Foundation for contributing to the report. The success of these things depends on a broad set of sponsors, and New York State Health Foundation's leadership is very much appreciated. Thank you. Next slide. So the first thing, we were charged with developing an implementation plan for high quality primary care. It assumes everything that Avital said in the setup, that high quality primary care is not only associated with, but causes better population health and improved health equity. And it's the only part of the healthcare delivery system that can say that. So how are we going to act on that evidence to actually implement it in the United States? The first thing we did was to update the definition of primary care. We had a really great group of people on the committee, including health center directors, nursing researchers, health services researchers, clinicians with a bunch of different backgrounds, people with health insurance background. I want to call out 3 things that I think are important for this definition of primary care. The focus on interprofessional teams. It's not a doctor, it's an interprofessional team. This notion of accountability for the majority of the individual's health, and the notion of sustained relationships. You've got to have a good primary care is a relationship between a primary care team and patients, families, and the communities, recognizing the importance of the social determinants of health. Next slide, please. So I'm going to cut to the chase. The big stories in this report is that high quality primary care is a common good. That means that it should be available to everybody, and our common goods, we require the government to have a role in stewarding them. That doesn't mean that there aren't other competing goods. It requires advocacy for that, for those public policies to promote primary care, but we rely on that public policy making process. The second point, as Avital noted, is that it is fragile and it is weakening in the US. I didn't appreciate before the report started how it is weakening over time. I understood the fragility, but we are, in the time we've been working on this, the last 10 years, primary care is weakening. It was weakened in a time of COVID. It continues to happen. The third punchline, which I think it might be important to your listeners, is that everyone should have a usual source of care. That's both a moral argument around everyone has the right to it, but also implies a responsibility that we as participants in the healthcare system can't bounce around willy-nilly, but need a place that we go most of the time for most of our care. And finally, the focus on money, this idea that we need to pay more and differently for primary care. The headline is to get practices off fee-for-service. So if you're a payment person, the headline is we're recommending that, led by Medicare, we move all of primary care to some mix of a per member or per patient or capitated payment and fee-for-service. And we can have a whole payment debate if you want. Next slide, please. So those are the headlines. There are about 21 recommendations that are captured under these 5 categories: paying for primary care in a way that promotes teams to care for people, not doctors to deliver services, ensure that high quality primary care is available to every individual family in every community, to train primary care teams, this workforce question where people live and work, not in hospitals, to design information technology to serve the patient and the family, and to ensure that high quality primary care is implemented in the United States. This notion of accountability. We can't just say it, we have to measure our performance over time and hold entities, the state government, federal government, the delivery system accountable for implementing these measures. Next slide, please. So the headline on the payment section is the committee is recommending a full phase out of fee-for-service payments to this hybrid payment system in the middle with resources for transformation. You can think of this sort of as a patient-centered medical home if for people who've worked in that area, but with patient assignment so that we are attributing, is the technical term, patients to particularly primary care practices based on their own selection. They say, this is where I choose to go. We ask that in Medicaid managed care. We don't ask that in commercial health plans. We don't ask that in Medicare. And I think this is an important insight for the committee. But then to note that depending on who you talk to, between 50 and 70% of doctors are employed. They're employed in large health systems that are consolidating. And while we focus on payment at one end, it's important to link the primary care work to larger efforts around healthcare payment and healthcare economics, and this idea that we have to get these health systems into population-based payments. It's important that they get paid on a per patient basis because that will force them to recognize the importance of primary care to succeed. Sorry to get technical, but so long as we allow our providers to be paid on a fee-for-service basis, those systems will be incented to go to high margin, high revenue services, which are specialty services, not primary care. Next slide, please. So in addition to the payment recommendations, we call for Medicare payment reforms because you are going to have to adjust the Medicare fee schedule to recognize the value of primary care. That's not new, but an old argument is still an important argument. And so we focus on that. And then we call attention, and I italicized it because we're talking about New York State, to the role of the states in facilitating multi-payer collaboration and increasing the portion of healthcare spending for primary care. And there's considerable action on that in New York that I imagine we'll get to. Next slide, please. This is the key access recommendations that I think affect state health policymakers. So we're not going to cover all of them. There's some that are national, but one is this idea of a usual source of care. There are opportunities to do this in Medicaid. You can do this in commercial insurance regulation. We think that creating that social expectation that everyone has a usual source of care and then it should be declared. So there's an obligation to provide it, including working on the workforce issues, but also for people to commit to that usual source of care. And then we heard a lot of evidence testimony about the role of Medicaid in strong primary care and the systematic underpayment of primary care by Medicaid agencies. We think as a committee, the best way to get at that is actually to call on CMCS, federal Medicaid, to impose primary care access standards on state Medicaid agencies, who will then impose it on their managed care contractors. But we need to pay attention to how much Medicaid is paying primary care. Next slide, please. I think this is it, Avital. We really wanted to focus on where, what are the particular state levers. So we don't focus so much on workforce, because those are workforce is mostly trained at the through federal monies, but we can talk about that if you want. And we don't talk about information technology because, again, those come out of federal standards for how electronic health records are developed, the fact that they're not clinician or family friendly right now, and how that information is shared, and the fact that right now there are barriers to interoperability, often constructed by providers who want to make the information proprietary. And I do think that there are opportunities for state level accountability, whether it's with organizations like the New York State Health Foundation, the Health Center Association, Primary Care Development Corporation, or others, to hold the state accountable for how are they paying attention to the health of primary care. So we can certainly talk about that if you want, but we have limited time and I want to make sure we get to the conversation. Thank you.
Great. Thanks so much, Chris. So everyone knows we'll be sharing the materials after the event, including the report, some of the summaries of the report that have been put out by the committee, so people can delve into that. And actually, Chris just wrapped up a series of really in-depth events that the committee did on various topics that are highlighted in the report. So we'll encourage everyone to check those out as well. So just kind of pulling on some of those last themes that you developed for us, I think we really want to focus a bit in this part of the discussion on digging into some of those payment spending type of recommendations that came out of the report. So first, maybe you just touched on this at the end of your presentation, but maybe you can dig a little bit more into some of the gaps or the opportunities and how states, including New York State, are approaching payment reform, approaching rebalancing spending towards primary care, and what are some of those levers that states can use to implement some of the changes and recommendations you noted, either more quickly, more broadly, more effectively? Maybe you could just give us a bit more of a picture on that.
Sure. So there's a lot of work going on in states, and I think the change has been what specific payers are doing, whether it's a commercial health plan or even Medicaid as a payer, to thinking more systematically about the health of primary care in the state as a whole. I think that the most significant work, and this is something that the Health Foundation has been engaged in, is legislation. I don't know the exact count now. I think there's legislation in about 5 and executive orders in another 5 to measure, and in some cases, increase the portion of spending in the system that is going to primary care. The example that I will lift up in particular is Oregon, which has been working at this for 5 years. They at least 5. They have a state definition of primary care. They have passed laws that direct both the Oregon Health Authority, that is the Medicaid agency, and the commercial health plans and Medicare Advantage to measure and increase the portion of the individual payer spending that is going to primary care. They don't specify how to do that. They just say you have to do that. You have to rebalance, to use your words, Avital, the portion of dollars that go into primary care. So I think the kind of state levers are certainly the way Medicaid spends, how much it pays for primary care, and then this overall balance. Medicaid can do that directly and through their managed care contracts. You have considerable levers around commercial insurers and insurance regulation. And you can actually, we did this in Rhode Island, Oregon's doing it, other states are doing it. You can ask the insurers, what portion of your dollars are going to primary care? That's not enough. We want you to increase it. Often you can, in that discussion, by the way, it's important to note that we're asking for is rebalancing, not an overall increase in spending. And I think, for people who are rightly concerned about affordability, that's really important. So you've got Medicaid, you've got commercial, and I think it's really important to have ongoing attention to this. So this role of an external commission some stakeholder group that is working regularly to hold the state accountable for the work that it's doing to measure the health of primary care. That consists of consumers, of providers, of community health centers, of employers. We need employers interested in this. And the goal here is not just to do right by primary care, but to do right by the health of the population. Because to your point at the beginning, primary care oriented delivery systems have people who live longer, we've shown that, and they have more equitable health care. And particularly at this time with this increased attention to the injustices of health inequity, I think that's a really important argument for primary care.
Absolutely. And maybe picking up on that thread, and then we can go back to some of the other recommendations from the report, but picking up the thread around the spending issues and rebalancing, like you said, I think there are 10 states at this point who have made either an executive order or legislative action. New York State ended the legislative session with 2 bills pending in the Assembly and the Senate that had made their way to committee that would have, this measurement, and then subsequently at some point, hopefully having some parameters for increasing spend. And you brought up the Oregon example, touched on Rhode Island. I know that when you were in Rhode Island, one of the things that happened there was with the commercial insurance market around accountability, some of this targeting of increasing spending started to happen there. And Rhode Island is one of the states that people have been looking towards as potentially an example to have some lessons learned. Can maybe you pull out some more of those key takeaways and lessons that you would say that you learned from being one of those first states to kind of take on this idea of rebalancing? And
so I think there are 2 levels of lessons. One, you can certainly do this within commercial insurance. There are some people who say, well, I'm concerned about the regulatory pressure of big government. What we found in Rhode Island is that health insurers will play by any set of rules so long as the rules are clear and they are enforced fairly. And so I think that there is actually less pushback from insurers. You're fortunate if you're working with local nonprofits, because I think they really recognize the dynamic. If, frankly, when we were doing this in Rhode Island, the folks at the insurer said, look, we would like to invest in high performing primary care. We can't because of the market powers of private negotiations. So if you can help us do this, if you can give us cover, if you can help us say no to the specialists who have the franchise, who are getting 5, 6, 7% rate increases, we'll welcome it. You just be our bad guy. And I think whether you do that through regulation or through legislation, there is that power to say that. I think the other thing we learned in Rhode Island is, and we didn't have it, and that's why I pointed to Oregon, is the tight coordination with Medicaid. We were doing things in Rhode Island out of commercial health insurance regulation. We had good relations with the folks in Medicaid, but we weren't mandated to coordinate our policies with one another. That's not the case in Oregon. Oregon is working across these different payer sectors, and that just gives you more power. You're not power in a negotiating sense, but more economic force. You're aligning these economic forces across both commercial and Medicaid, which is really important, not to get too technical, but you have a significant part of commercial that is self-insured, that doesn't answer to state regulation. Large employers set their own rules, and insurers can't change that. So it's really important to create the rules in the fully insured and the Medicaid markets, because that has more of an influence on the self-insured market. You're on mute, Avital.
I'm on mute. I should know that by now. I should have learned. So that actually brings us a little bit back to this idea of one of the specific recommendations from the report that you touched on in the presentation portion, but the multi-payer collaboratives as a potential solution, both that states can scale up potentially. Can you share a little bit more, through your work in the committee or your work at Milbank, how states and others might be able to facilitate more and better primary care by using multi-payer collaboratives as a solution? What might those look like, both from the perspective of this rebalancing of spending, but I think also as a effective payment reform intervention or option?
So I'm gonna work backwards. I'm gonna give an example of multi-payer collaboration from your home state. It's COVID. The communities are reeling. The insurers are trying to help out. We did a blog. I did this with Tony Shee from the United Hospital Fund about the response in Buffalo. two nonprofit regional insurers, the local Blue Cross and Independent Health. And they, because of a history of working together, were able to reasonably align, it wasn't lockstep, their measures to support primary care in that setting, around how they paid for telehealth, around how they relaxed quality measures, around efforts to advance on a capitated basis. How were they able to, and as a result, primary care in Western New York fared relatively better. They weren't, swimming in clover by any means, but they were doing relatively better because the payers were aligned. Why were the payers aligned? Because they had been working together on the Comprehensive Primary Care Plus program set out by Medicare. Medicare created the opportunity for them to come together and learn how to work on issues in some areas in an aligned way when they were competing in others. So those are the benefits of that multi-payer alignment. You can have the feds calling for it, and Medicare has done this in a number of their primary care programs. You can also have the state doing it. You can have states through their commercial insurers. I think that's often the way to do it, is to call the insurers together and say, look, we're going to work together on this because it's important for the community. I know there have been discussions in the Adirondacks around multi-payer alignment in a bigger way around accountable care organizations. There are good discussions to go on in the Capital District with CDPHP and MVP, again, driven by the Comprehensive Primary Care Plus program. So it's the state or the federal government saying to the insurers, this is in the public interest. Let's get together and figure out how to do it. You can't expect the insurers to do it by themselves. But if the states do it, Rhode Island, they did it after I left around quality measures, came up with a small number of quality measures to hold primary care accountable to kind of stop the madness. It's a great opportunity to get the payers aligned, which they can't do by themselves.
And are there certain outcomes, that maybe in Rhode Island or other states that we could look to, positive outcomes that have come out of those collaboratives, even on a small scale?
I think the first, easier than money is quality measures.
Yeah.
It's a little bit technical, but primary care providers, all providers, are driven crazy by the different quality measures that providers use, that health plans use. And if someone can get together with the health plans and say, stop the madness, let's align on these measures, you deliver relief right away. So that's the lowest hanging fruit.
Great, thanks. And so I think, one of the things that we haven't quite touched on yet, but it's been a little bit of a thread throughout, is what role, in addition to maybe the states, the Medicaid office at the federal level, Medicare, what are some of the roles that the health systems themselves play in moving towards either some of these multi-payer collaborations or, this idea of, kind of rebalancing spending? Where do you see the health systems fitting in?
I think the health systems are, I don't know how to dance around it, are some of the greatest challenges to this. There are health systems that have worked really hard during COVID to respond. And very appreciative that they're there, the level of collaboration. But we have to understand, a primary care oriented delivery system is not in the interest, the economic interest of health systems the way that they are paid currently. And so I would actually say, if we want health systems to be more aligned with a primary care oriented delivery system that is focused on population health and health equity, we have to make it in their financial interest to do so. And that means really pushing population-based payments. Too often, health systems enter into population-based payments that have what we call upside gains only. So if I save money, I'll get some of it back. But if I lose money on this per population basis, it's not my problem. And that is how a number of Medicare accountable care organizations are set up. And as health systems get bigger, they have the ability to dictate the pace in private negotiations. That's the problem that we're going through in consolidation. If we could get health systems to be committed to population-based payments, as is the case in Maryland, where they have all payer rate setting, then what happens is they wake up and they say, goodness, I need to pay more attention to my primary care. I'm not going to advertise my wait time for my emergency rooms. I'm not going to advertise how great my orthopedists are. I'm going to advertise how great my primary care is. So if we want to get health systems aligned to this, we can't just expect them to wake up and take the pledge. We need to make it in their financial interests with promoting these population-based payments.
Got it. No, that's great. So, and I think, in New York in particular, we talked some of this throughout the last few questions, but obviously, over the past several months, the Medicaid program has, even grown. We've shown what a amazing safety net the Medicaid program has been and been put to the test. But it means, obviously we have a significant portion of New Yorkers who are enrolled in some sort of Medicaid managed care program. Can you maybe talk a little bit more about where you see some of those opportunities for state Medicaid to really be the one who's pushing the needle on some of these issues, and also maybe facilitating some of that collaboration that you mentioned?
Well, first of all, hats off to policymakers in New York and all but, 9 other states that have expanded Medicaid access. Because you can't expect to have good population health, better health equity if people don't have the ability to have their healthcare finances covered. So we've got that base going in New York. And I would note, as a result, if you look nationally, we have health inequities in New York. They are what would I say? I don't want to call it reprehensible. They're inexcusable. They are an injustice, but they're not as big as they are in other places. So we can show that public policies reduce health inequities, including Medicaid access, as well as things on the social determinants of health. I think, as we said in our report, Medicaid can continue to pay attention to how their health plans pay for primary care, and frankly, be more directive with the health plans around their activities to promote primary care. And I think, and you and I were talking about this before we came on, I think Medicaid is a primary vehicle for health equity in this country. And so for Medicaid, we're not promoting primary care just because primary care is great. We're promoting primary care because it helps people live longer, and it helps people, it improves health equity. And so what can Medicaid do, completely independent of primary care, to draw a bigger attention on existing health inequities and strategies to change that? That means making sure your race and ethnicity data is really good. That means producing that information. That means engaging communities, because health equity is going to look different in Messina than it's going to look in the Bronx, and so you have to get the community input to that. And I do think, we've been talking about this in other studies, there's a really important role for community health centers in this discussion, in Medicaid, in health equity, in primary care, because they do community-based primary care. Many of them do this interdisciplinary workforce that we call for, and they have the ability to take in community input because of the way they're structured. So engaging the health centers in a broader conversation. So it's not just about safety net providers, but it's about the population as a whole. And Medicaid can help with that.
Great. And I think, we're coming to the close of the time. We have a few more minutes that we can stay on the line. If any of the audience has questions, feel free to put them in the chat. If we don't get to them in this last few minutes, we'll address them through the recap or individually. So just leaving that open for others. I think one of the things, as we think about the closing thoughts, Chris, I think what you just touched on is in some way kind of a really important point that to leave us off with today. But I'm just curious if you were to, kind of put all of this together in terms of some of the fundamental changes that might need to happen within the systems, and, where some of those levers are. Is there something you want to leave the audience with today in terms of, especially from the perspective of payment reform and rebalancing spending?
Well, I think particularly for the folks who are on this call, I would encourage all of us not to let the experts, what I call the 20%, meaning the 20% of the economy that is healthcare, to run the conversation. It's really important to get, for instance, employers engaged in how their premium is going. It's important to get consumers engaged about, are they actually getting high quality primary care? If I make you select a usual source of care and what you get for it is someone who is closed between noon and 1 and shuts up at 4, that's not high quality primary care. It's got to be available when we want it. And only consumers can make that change. And I think it's also, frankly, important to get what I call the other 80% engaged in this conversation, because there is an enormous economic incentive for these growing health systems to continue the status quo. And the status quo is not improving population health. It's not improving health equity. And so those of us who are involved in primary care wonder to what extent our allies are not so much people inside that 20%, but the folks in the other 80% who are concerned about affordability, who are concerned about health equity, who are working to address the social determinants. And I think the people who gather in the New York State Health Foundation calls are folks who kind of straddle both worlds. They're health folks, but they're also thinking about the social determinants of health. They engage in that other 80%. And so having the folks on this call who are fluent on this and not willing to just sort of accept the status quo within healthcare by representing the voices outside of it, I think is really important.
Absolutely. And actually, I'll have us answer one more question, because a question came in that's so related to what you were just speaking about. For those of you that have to jump off, you'll get the recording with this last few minutes. But one of the points that one of the audience members just made is that the report did acknowledge that idea of social determinants of health as an important driver, and an important social determinant of health is primary care. And so the question that came in is, how do large health systems, how do we encourage large health systems to share in some of that global payment with CBOs, with community-based health organizations and other organizations that might be delivering the services in that social service space? We know there's a lot of challenges there, I think, in terms of sharing those payments, but any closing thoughts on that? Because it really touches on some of what you just discussed.
I'll give the example from Maryland. So, which is an all-payer rate setting state. It's the only one that's left. And I've heard the former health director tell this story. It wasn't until the hospital in Cumberland, Maryland was placed on global payments, meaning they were getting paid on a per person basis, that the hospital administration said, why are we having all these kids coming into the emergency room with suffering from diabetes and asthma? And we don't want these kids in our emergency room. Previously they could say that, but they still got money for every kid who came into the emergency room. Now they're not. They're getting on a per capita basis. And that's what got the hospital to invest in school nutrition, to pay attention to the schools and what's going on. So the lesson for me is that if you're a community-based organization and you want to partner with hospitals to help them reduce the number of people with behavioral health crises who are popping up in the emergency room, the number of homeless people who are showing up at the emergency room because it's a place to spend a cold night. You've got to get that health system onto population-based payments. You've got to help your Medicaid agency enforce those. You have to help your commercial insurance regulator. You have to help Medicare get these health systems to accept population-based payments, because once they do, they're going to need your services. They're going to need what you're selling. Until then, they'll give you money because you have some political power and they want to be nice to you. But when it's really in their economic interests, then you're going to have some serious conversations because your interests will be aligned.
Thanks. That's a helpful note to leave on. Thanks for everyone for staying a few extra minutes with us. Chris, thank you so much for sharing your thoughts, perspectives, and a bit of an overview of the report. Just as a reminder to all of our audience, we'll be sharing around the materials from today's events. You can dig into the report more. There's some great materials on the National Academies website. And so we'll make sure all of you receive those in the coming days. And please take a look at the New York State Health Foundation events page. We have some great additional events coming up for the rest of the summer. And on that note, I wish everyone a great rest of the day and stay cool. And thanks for joining us.
Thank you very much. Keep up the good work.
Thanks, Chris.